Hello, my name is Anthony Looney. I'm a nurse practitioner student in Northern Kentucky University's AGACMP program. I am currently in a diagnostics and imaging class, and today's video I have to talk about chest tube placement. Um, Another term for that is thoracostomy tube, but most everywhere calls it chest tube. Basically, you need a chest tube whenever fluid or air or blood is causing compression of the lung. So your lung is basically collapsed. So pneumothorax is the word for a collapsed lung. When that happens, we have to insert a tube, we place it to suction, and that creates a negative air space for that fluid to leak or that air to leak, and then the normal capacity of your lungs re-expand. The chest tube placement, it can not be an emergent situation, but a lot of times in the critical care area, it's an emergent situation with tension pneumothorax and that kind of thing. Other issues can happen, like people develop empyema. They have to have that drained out of their lung. That would be like a less emergent. Of course, that's going to affect their ability to breathe, but you might be able to take your time, go to a procedural area, get sedation, have everything sterile, that type of thing. But sometimes this can lead to hemodynamic instability if it's a tension pneumo, or just a regular pneumo that hasn't progressed to tension pneumo yet. And your patient's blood pressure will be low, your heart rate will be high, and that's because the collapsed lung is causing the other lung to compress, and you're backing up your venous circulation. The pressure for your heart to beat becomes harder, so you become hemodynamically unstable. So this could be an emergent thing that you have to recognize. And some of the providers that I've worked with before, they'll pull ultrasound in the room, they'll look at the lung, see if they can see lung sliding, they'll listen to breath sounds. You'll have absent breath sounds on a collapsed lung. And then you'll have to gather supplies, emergently place this chest tube, and watch for hemodynamic stability to come back, hopefully. So I wrote down a list of things that you'll need for chest tube placement, and that would be the actual chest tube that goes into the thoracic cavity. You will need like chlorhexidine or some other type of cleanser. You'll need a scalpel. You'll need like a Kelly clamp or needle driver, sutures, and you'll need suction, some sort of Pleurovac system, so that you can hook your suction up to it and create that negative pressure. And then make sure you have all your connector pieces, and also you want to make sure that your patient is on the monitor. You need to be watching their rhythms and make sure your patient's hemodynamics, yes, they are going to be declining probably on a lot of these patients, but we got to make sure we don't need to do ACLS. So your patient is going to be positioned supine, hopefully like this. And the landmark that you're going to look for is the nipple, and then you're going to come over from the nipple to the anterior axillary line. So the nipple's here, the line's here. The chest tube insertion will be right here at the fourth intercostal space. You'd palpate it, and then you would use your scalpel and create an incision, and then you'd use your clamp and you would go up inside the thoracic cavity. Using that dull instrument, you'd continue to go up, and then you would slide your tube by your clamp until you were inside the thoracic space. Once you're done with that, your tube would have connector pieces, and you would hook it to an atrium, to some suction, or sometimes it's just to water seal. But the point is that you want that air to come out that caused the pneumothorax, or you want that fluid or blood to come out if it's a hemothorax. And once that's done, of course, you're going to get a chest x-ray after. You're going to monitor, make sure your patient's hemodynamics are becoming more stable, not less stable, because you can actually cause like a different tension pneumo. You can affect the heart accidentally, maybe hit some arteries. I'll say that, like, as far as contraindications, normally if something is happening to your patient where they're requiring an emergent chest tube, every procedure you're going to weigh risks and benefits of that procedure. But this is something that's like compromising your oxygenation, compromising your hemodynamics. So there is all kinds of benefits, and while there is risks, you have to go for those benefits in this situation. One thing that you might want to think about is coagulopathy if somebody is on blood thinners or if their platelets are extremely low, because all those ribs, and you're going right between the fourth and fifth interthoracic space of the ribs, they all have their own blood supply, and so like you could technically accidentally hit one of those and cause your patient to bleed a lot. So that can happen. And then basically you want to get a chest x-ray. You're going to want to confirm placement. Lots of these people end up intubated. Sometimes not, though. I've had plenty of patients that didn't require intubation because their pneumothorax was caught quickly and a chest tube was placed. Now, we'll also go ahead and discuss that is more emergent. You got to get it done. Obviously, you still want to try to call a timeout. You want to make sure you're going on the right side of the patient that the appropriate pneumothorax is occurring on. But let's like tone it down and act like this is like we got more time to do some things. Maybe it's having a procedural area. You would definitely have this patient draped sterilely. You would make sure that this patient, you have the right patient, the right side. And you would do that anyway, but you would just be working much more quickly if this was an emergent situation. Most of the time, chest tubes go at -20, but you know, differing providers want different things. I've had it put to -40 before. I've had it to water seal. And then also the size of your chest tube. This particular video, I'm talking about the bigger chest tube, but sometimes providers will put in like a pigtail that can be even clamped off, and then like you can hook it up to a negative pressure device that will drain fluid from your lung. But you want to when you are checking your x-ray for post-placement of these tubes, you're just making sure that it's in the pleural space and that it's not somewhere it shouldn't be, like the peritoneal area, because that can happen. I'm going to say that I'm done covering chest tubes. I'm sure that I will remember something more, and I'll type out a brief description of that in the discussion post. Thank you guys for watching.